Okay, thank you very much. Good morning, everyone. Assalamu alaikum. It's always good to be in hometown and see many familiar faces, old teachers, old friends. My name is Dr. Faisal. I'm currently working as consultant head and neck surgeon at Shaukat Khanum Cancer Hospital. And with me, I have my team, Dr. Rahim Danani. He is consultant ENT head and neck surgeon. He has worked with us as fellow in head and neck surgery, and he's going to join Ziauddin as consultant. Uh, Other than this, Dr. Samiullah, the man with the golden hand, he's our plastic surgeon. He is probably leaving in July to University of Birmingham, UK, for his advanced training in microvascular reconstruction. And we have Dr. Samin as well. She is one of the vibrant resident in general surgery. She wanted to accompany us. I hope she will learn a lot from this session as well. Okay. I can't change the slide. Okay. So the real monster in the house, the oral cancer. Nobody is spared from this disease. You can see a man, Grover Cleveland. He was an alcoholic, tobacco user, and president of United States. He has served the term twice, 22nd and 24th. Got an oral cancer, lived with it for 15 years, and finally succumbed to the disease. The next one is very famous one, Sigmund Freud. He was an Austrian neurologist, founder of psychoanalysis. He got oral cancer, lived with it for 16 years, has had multiple surgeries. Surgeons have built prostheses for him. He called them the monster. He also died of the disease. You can't see the next one. Okay, Eddie Van Halen, the guitar god, lived the life of a rock star and succumbed to the disease. He got tongue cancer as well. So nobody is spared from the disease. So the basic outline of today's presentation is the global burden of the oral cancer, the epidemiology, the risk factors which are associated with the disease, diagnostic modalities, including the workup, TNM staging update. We have moved on from the 7th edition to the 8th edition of TNM. The importance of multidisciplinary team approach, treatment options for the early and advanced stage disease, the management of neck disease in oral cancer, and finally the reconstruction and rehabilitation. So we know cancers of the oral cavity and lips collectively represent the 6th most common cancer worldwide. Every year, 355,000 individuals got this disease, and out of them, 177,000 die of the disease. So you can understand the gravity of the situation. According to the recent statistics by Globacon 2020, the incidence of oral cancer, including the lip cancer, is 9.5%, with the mortality rate of 9.1% and the 5-year prevalence rate of 9.90%. In the very first graph, you can see that the number of new cases in 2020, the oral cavity cancer stands the 2nd most common cancer, including both sexes, which is male and female. But when we talk about the male, it is the most common cancer in our society. And in females, it is the 2nd most common cancer. So there is a gradual trend towards developing oral cancer in females as well in the last few decades. When we look into the age standardized incidence rates per gender, we can see that for the lip and oral cavity, the rate is 13.2 for the males and 7.0 for the females in 100,000 individuals. And the mortality rate for the male is 10.1 individuals per 100,000, and for the females is 6.4. When we look into this chart, it was the Globacon statistic in 2018. The incidence is very high in Papua New Guinea, but when you look into the mortality, Pakistan stands out. So we know the risk factors: tobacco, You have to see whether the patient is smoker or non-smoker, because the risk increases 3 times for the smokers. And then it's a dose response relationship. Whether you are smoking 15 cigarettes per day or more than that, the risk increases. For alcohol, the risk increases 2 to 3 times, but there is always a synergistic effect when you take alcohol with tobacco, and the risk is 20 times. The betel quid, the third most common factor, there are 600 million users worldwide, and most of them are in Southeast Asia. It is one of the strongest risk factors in our population. When you are combining the 2 risk factors, which is betel quid with tobacco, the risk rises to 15 times. In 2010, there are 6 million deaths worldwide, and the expected rate is going to rise to 10 million by 2040. HPV, obviously it has a role, because in the past, we used to have oral and oropharyngeal cancers. It has a certain role in oropharyngeal cancer, but the study which we have done in Shaukat Khanum, we didn't find any role of HPV in oral cancer. But I think there was one study in Afan Hospital where they find a role of HPV in oral cancer as well. So we need to look into this statistic as well. For the diagnostic work, there are 4 basic things. The physical examination, the most important one. You need to have an eye of the tiger. Imaging, biopsy, which is the gold standard for the diagnosis of the disease. And then you have to stage these tumors. I'm sure there are many more residents in this hall who are the residents in maxillofacial surgery. So they will get to know the importance of staging in oral cavity cancer as well, because your treatment change depending on your stage. And then you can stratify your patients as well. So in this picture, you can see that there is a diverse range of the morphology of this cancer. In the very first picture, you have an exophytic papillary appearance in the right buccal mucosa. And then as you see in the other picture, it's an endophytic infiltrating tumor in the floor of the mouth. In the third picture, you can see there are 2 separate foci of tumor present on the right lateral tongue. In this picture, you can see that there are synchronous tumors, the first one on the tongue and the other one on the buccal mucosa. And then there is an exophytic appearance of a tongue tumor in this 5th picture. And then you can have a patient who can have a traumatic ulcer, which looks like a cancer, but the rule stays the same. If the ulcer is there for more than 2 or 3 weeks, you need to have a biopsy. Moving on to the imaging modalities, there are CT scans, MRI, PET scan, SPECT, OPGs. So there are proponents and opponents of all these modalities. CT has a sensitivity and specificity of 82 and 80%. It is a good imaging modality to detect the primary tumor and the metastasis in the lymph nodes. It is the gold standard to identify the early bone erosion and focal metastatic deposits in the normal size lymph nodes. You need to have a CT scan which should cover the areas from the base of the skull to the clavicle with 4 millimeter slices. And the areas which you need to emphasize need to have a 2 millimeter slice. The drawback is obviously when you have dental fillings, there will be artifacts. And you need to identify those patients who has dental fillings, particularly amalgam. It has a sensitivity and specificity of 85 and 90%. It is a good imaging modality when you want to delineate soft tissue. And you need to see the primary tumor extension. MRI is an ideal modality when you want to see the perineural invasion or spread and the intracranial extension of the disease. Obviously, there are drawbacks. Motion artifacts are there. For an MRI, your radiologist will identify the disease with these 4 types: T1 weighted, T2 weighted stir, and TW axial images and coronal images. I think these are enough for a radiologist to detect the disease. PET-CT. There is a lot of published literature on the role of PET scan in oral cavity cancer detection. There's a debate whether it has to be done pre-treatment or post-treatment. It's an established modality to rule out distant metastasis, to identify synchronous primary tumors, and the PET-CT can upstage the disease as well, because the risk of second primary malignancy is 3 to 7%. And it has a role in stage 3 and stage 4 disease, because these are the patients where you suspect distant metastasis as well. PET-CT has a definitive role in carcinoma of unknown primary to determine positive lymph nodes after the treatment and to rule out distant metastasis, which is an incidence of 7 to 25% in advanced stage disease. And when I say advanced stage, it means stage 3 and stage 4 disease. There's a very famous landmark paper by Hisham Mehna, which was published from University of Birmingham. It's fine. So the PET-CT has an established role in the post-treatment surveillance, but there is a specific time when you need to have a PET-CT. You can't order a PET-CT for a treated patient right after 2 weeks. It's useless. You will find the surgical fibrosis, inflammation. So you need to wait actually for 8 to 12 weeks before you send the patient for a PET scan. Tissue diagnosis, it's very important. You can have multiple biopsies, but the diagnosis is atypical squamous proliferation. It means you are not hitting the target. So tissue biopsy is the gold standard for the histological diagnosis of oral cancer. What are the common errors? You are doing superficial biopsy. It's useless. Specimen taken from the center of the lesion. Center of the lesion is the area where the blood supply is compromised. You will always come up with a necrotic tissue. The infiltration of loads and loads of local anesthesia around the tissue, distorting the normal periphery. Crushing of the tissue with the instrument. So you need to be careful with your instrument handling. You're handling a soft tissue. And then the use of electrocautery or laser. You can't do a biopsy with these tools. So scalpel is the right tool for biopsy. You will obviously read so many adjuncts in your maxillofacial ENT head and neck books, which include toluidine blue, Lugol's iodine, chemiluminescence, and autofluorescence. But these are all adjuncts. They will actually help you to identify the area where the tumor is culminating, but they are not the gold standard for the tissue diagnosis. TNM staging. As I told earlier, that there is an update from the 7th edition to 8th edition back in 2018. And the most important incorporation by AJCC is the depth of invasion. In the new classification, TX-TIS is the tumor cannot assess, and carcinoma in situ. For T1, it's less than or equal to 2 centimeter with the depth of invasion of less than or equal to 5 millimeter. For T2, it's less than or equal to 2 centimeter with a depth of invasion of 5 to 10 millimeter, or 2 to 4 centimeter tumor with a depth of invasion less than or equal to 10 millimeter. And for T3, tumor which is more than 4 centimeter or a depth more than 1 centimeter. And then T4A, moderately advanced and very advanced tumors. Obviously, for the advanced tumors, the disease is unresectable, means involving the masticator space, pterygoid plates, and internal carotid artery. In the end stage, N1 is one node which is less than or equal to 3 centimeter with ENE negativity, means no extra nodal extension. For pathological N2A, it's one node which is less than or equal to 3 centimeter, ENE positive, or one node 3 to 6 centimeter, ENE negative. Pathological N2B would be multiple nodes which are less than or equal to 6 centimeter, all ENE negative. And N2C is the bilateral or contralateral involvement, less than or equal to 6 centimeter, all ENE negative. And then N3A, which is a node more than 6 centimeter, ENE negative, or one node more than 3 centimeter with ENE positivity, or multiple nodes, either ipsilateral, bilateral, or contralateral with any ENE positivity. So this is the change in the 8th edition for the oral cavity tumors, particularly the depth of invasion. And when we talk about the depth of invasion, there's a difference between tumor thickness and depth of invasion. In this picture, you can see an exophytic tumor coming out of the normal tongue mucosa. That's the tumor thickness. You can see here. But then there is an endophytic part of the tumor, which is this one. And you measure it from the normal mucosal surface to the deepest most part of infiltrative lesion. In this scan, you can see that there is an exophytic component, which is this one. This is the normal tongue mucosa, and it is the endophytic part. So you measure from the deepest part to the normal mucosal surface, which you call depth of invasion. As we have seen earlier, the T1 is less than or equal to 5 millimeter, T2 is 6 to 10 millimeter, and for T3 it's more than 1 centimeter. We have conducted a study on the depth of invasion as a predictor of cervical nodal metastasis and local recurrence in early stage squamous cell carcinoma. We have enrolled 179 patients, and our results have shown that the risk of recurrence and nodal metastasis for group A, which was depth less than 5 millimeter, is 15 and 23% respectively. So all those patients where depth of invasion was less than 5 millimeter, they had occult metastasis of 23%. For the depth, which is more than 6 and less than 1 centimeter, the occult metastasis was 34%. And when the depth was more than 1 centimeter, the risk is crossing 50%. So you cannot spare neck dissection in all these patients, even for the superficial tumors. This is what we have seen. Regarding the treatment strategies, you need to look into patient factors, tumor factors, and then the care team factors. When I'm talking about the patient factors, the important things are age, the comorbidities, the compliance of the patient, socioeconomic status, geographic status, and then the lifestyle. The very important one is the tumor factor. Which site is involved? What is the location of the tumor? What is the size and depth of the disease? Whether the bone is involved or not, whether the node is involved or not, the histology of the disease, and has the patient undergone any previous treatment? Because that will change the entire outcome of your treatment. And out of all these, the care team factor is probably the most important in the current situation. You need to have a tumor board meeting. You need to work in a high volume center so that you can show your results. You need to have a surgical experience. You need to have years of experience behind your expertise. And finally, you need to have a rehabilitation service. As Dr. Said said, you need to listen to these patients. It's not only cutting the patient, operating the patient, and sending him home. You need to work on the patient. You need to have a psychologist, speech therapist, dietitian, right? What are the goals of treatment? complete removal of the tumor. As we know that in oral cavity cancer, only 35% patients present to you in early stage, which is T1 and T2. And that is the dilemma. We see patients at stage 3 or stage 4. And you can expect an adverse outcome for sure. The other objective is the restoration of form and function, and the minimization of treatment-related complications and side effects. So here I would stress the importance of MDT. It's a very nice statement. Given the complexity of multimodality treatments used for cancer, no medical profession, I would say again, no medical profession can have the necessary background knowledge to make an optimal decision independently or avoid inevitable unconscious bias towards their own area of expertise. In England, before 1990, only 20% patients have gone through MDT decisions, but the trend is changing. After 2004 or by 2004, more than 80% patients are treated after having an MDT discussion. So what are the benefits of it? You are getting the most useful information from all the respective specialties. It will decrease the time to recommend treatment. Your patient is not roaming around meeting the surgeon, the radiologist, the medical oncologist, the speech therapist. You're working under one roof. There is collaboration and sharing of knowledge, coordination and continuity of care, and better communication with shared decision making. So everything revolves around your patient. As I told earlier, you need a head and neck surgeon, medical oncologist, radiation oncologist, a good plastic surgeon, a good nurse, dentist, speech therapist, and so on. And every individual has its own role. Resectability is dependent on the head and neck surgeon. Function is depending on the plastic surgeon. Whether the patient needs adjuvant treatment, your radiation oncologist will decide. Is there a need for chemotherapy? Your medical oncologist will decide. How would you stage the disease? The role of radiologist is very important. And the purpose of this is appropriate treatment decision. So there are some statistics regarding the outcomes in terms of MDT discussions. There is a study in 2002 which shows that the staging has been revised after the MDT. Distant mets have been identified in 1.5% of the patients. There was a change in treatment plan without change in diagnosis in 59% of the patients in one of the study which was published in 2010. And then Brunner in 2015 has published a study which showed that there are changes in treatment in 30% of the patients, change in treatment modality in 67% of the patients, and change in treatment dose and field of radiation in 33% of the patients. So in an audit in South and West regarding the head and neck cancer in UK, they have observed an improved survival in their MDT cohort with a significant p-value of 0.02. And there was one more study in Ohio State University in USA, which showed a survival benefit of 61% in MDT group when compared to non-MDT group. And Fredland in Australia have shown that stage 4 disease treated with MDT have shown significantly improved survival with a p-value of 0.004. So when we talk about the early stage disease, I'm talking about T1, T2 tumors. There is always a comparison offering surgery or radiotherapy. There are many more proponents and opponents of this treatment modality. Surgery gives you the immediacy, shorter hospital stay, availability of histological information to guide your radiation oncologist for adjuvant treatment. And then there are side effects of RT as well, which are acute and late toxicities. So you can see in this graph that there is a comparison between surgery and radiotherapy regarding survival in early stage disease. So your treatment choice depends upon the site, as I told earlier, location, stage, histology, and nodal status of the disease. But you have to consider the complication, compliance, convenience, cost, and competence of your treatment when you are treating these patients. The management of neck in oral cavity squamous cell carcinoma. We know that the neck nodal disease is the single most important prognostic factor affecting the survival in these patients. And once you have the disease in the neck, your survival decreases by 50%. So one will advocate the elective neck dissection when the probability of metastasis is more than 20%. There is a landmark paper by Weiss et al. In oral cavity cancer, the risk is obviously more than this. So you'll have to address the neck. Based on current TNM classification, the risk increases by the tumor size and the depth of invasion. And in clinically node negative patients, the risk of occult metastasis by and large is always more than 20%. So on average, it stays at 30%, which compels you to perform neck dissection or elective neck irradiation, which most of the radiation oncologists propose. So there is always a clinical equipoise in terms of the management of neck in early stage disease. Whether to perform elective neck dissection or not, in all the previous studies and published literature, we have observed better operational control and survival for the patients who were subjected to elective neck dissection. There are 3 randomized control trials over 5 decades from 1966 to 2009 for T1, T2, and not tumors involving tongue and floor of mouth, showing better outcome with elective neck dissection, but no statistical significance. But the debate has been settled by one of the landmark paper published by Neil D. Cruz from Tata Memorial, showing that overall survival is 80% for patients who were subjected to elective neck dissection versus 67.5% for those who were put under surveillance. So the debate is settled now. There's another thing which is watchful waiting. The people who propose wait and watch policy, they say that unnecessary dissections have been performed in 2/3 of the patients because they don't find metastatic disease in the node. There is morbidity and cost related to the neck dissection. But our personal point of view is that you need to stratify your patients. You have to be very specific when you are addressing the neck or you're leaving it. So if you want to leave a neck, there are certain situations, T1, T2, lip tumors, because the risk is always less than 10% in early lip tumors. You can spare the neck in these patients. When we are talking about the high risk sites, which are tongue and floor of mouth, if the disease is less than 3 millimeter in terms of its depth, you can spare the neck. But there is always a debate who can accurately assess 3 millimeter, because there is a thin difference between 3 millimeter and 4 millimeter. And for the floor of mouth tumors, which are the highest risk, you need to identify those patients having a depth less than 1.5 millimeter. Again, something which is relative. The next thing would be the extent of neck dissection. So we have moved on from the days of radical comprehensive neck dissection to selective, elective, and functional neck dissections. There have been many published papers starting from 1938 to 1990s. A lot has been studied regarding the metastasis from the primary tumor site to the regional lymph nodes, and they have devised that it all happens in a predictable and sequential fashion unless your neck is previously treated or irradiated. Then you don't have a predictable sequential drainage from the lymph nodes. And the risk of occult metastasis is always limited to a selective group of lymph nodes. You can't have a primary tumor of tongue and a level 5 lymph node. It's not possible. Level 2, 3, 4 have to be involved before the disease travels to level 5. For oral cavity squamous cell carcinomas, the risk of metastasis is to level 1, 2, and 3. And the metastasis rate is 58%, 51%, and 26%. So level 1 is something that you need to address because it is at the highest risk, then level 2, and then level 3. In 1997, Byers et al. Have coined the term of skip metastasis to level 4, which as per his study was 15% for oral tongue squamous cell carcinoma. Then Khafif in 2001 have shown no evidence of isolated level 4 involvement. And this is what we have observed as well. You need to have a positive lymph node at level 2 or 3 before the disease goes to level 4. For the oral cavity tumors, we are all agreed that the risk is anyways more than 20%. For the tumors which are less than 3 millimeter thick, the risk is only 8%. So theoretically, you can spare these necks. But again, it depends. Because if the patient fails in the follow-up, the overall survival decreases by 50%. Then we talk about the advanced stage disease, which means stage 3 and stage 4. We have moderately advanced local disease involving the maxilla mandible, inferior alveolar nerve, floor of mouth, skin of face, and maxillary sinus. And then the very advanced and probably unresectable disease involving the masticator space, pterygoid plates, base of skull, and the disease involving the internal carotid artery. There are some factors which govern surgical approaches to locally advanced disease. You need to have an eye to achieve negative resection margins. If you think you cannot achieve negative resection margin, there is no additive benefit of cytoreduction or debulking. And then obviously with the advanced stage disease, you can expect a huge defect. You need to have adequate reconstruction for a meaningful quality of life. And for the oral cavity, we need to have a reasonable form and function, which includes speech and swallowing as well. When I talk about the advanced stage disease, imaging is very important. CT obviously gives you the information about the bone involvement, the extension of tumor to the base of skull, and the encasement of carotid artery. MRI has a beneficial role when you're looking for intratemporal fossa involvement or prevertebral fascia involvement. PET CT has its own merits, its own indications when you're looking for distant metastasis in N2 N3 disease, where you expect nodal involvement at lower levels. And then CT thorax, obviously to rule out pulmonary metastasis. Surgery should be the mainstay of treatment when compared to upfront chemo-RT. But when I say this, you need to be very clear whether you are going to achieve negative resection margins. Again, there are multiple published papers and studies. And then there are outcomes from the National Cancer Database in UK. And then there are 2 randomized controlled trials showing that the surgery followed by radiation therapy has a 3-year survival of 49.7% as compared to chemo-RT upfront, which is 36% only in advanced stage tumors, T3 and T4A. So surgery and radiotherapy, 3-year overall survival is 59.1% versus chemoradiotherapy in T1 and T2 disease. So we are clear that for the early stage disease, surgery has a significantly important role to play. And for the advanced stage disease, surgery with negative margins followed by chemoradiotherapy has a beneficial role. But upfront chemoradiotherapy, you can see that the survival goes down. So what are the indications for postoperative radiotherapy? A closed margin, multiple positive lymph nodes without extracapsular extension, perineal invasion and lymphovascular invasion, T3 and T4A disease, and positivity of lymph nodes at level 4, 5 for orocavity and oropharynx primary. The only beneficial role of chemoradiotherapy combined is in the case of positive margin or extracapsular spread. This is the certain criteria where there is benefit of disease-free survival, but the overall survival doesn't change. Many old people must be familiar with this space, the anti-gum, the man without a mandible. So you don't want your patient to be orally crippled. You need to look for aesthetic and function. And when I talk about aesthetic, it has to be a contour, expression, competence, and lip sport. And in terms of function, speech, mastication, swallowing, oronasal barrier, dental rehabilitation with fixed or removable implant based dentures. For the glossectomy defects, there's an algorithm. It's good if you learn this algorithm for your exam. So when the defect is less than 1/3, you can opt for no reconstruction or split thickness skin graft. But for a split thickness skin graft, it has to be perfectly immobilized. I think some of you would agree to that. But tongue is a mobile structure. For the defects involving 1/3 to 2/3 of the tongue, you need to have a thin pliable flap because you have to maintain speech and swallowing. And the flaps, which are ideal in such situation, are radial forearm, lateral arm, local flaps, which include nasolabial, submental. But then again, there is some nuisance attached with the use of submental flap. People have hair growth. There is always a theoretical risk of positive lymph node in level 1. When the subtotal glossectomy is performed, you need bulk, the muscle bulk. You can have ALT or serratus flap. For the total glossectomy defects, I don't know how good is the quality of life for these patients, but people have used much more bulky flaps like rectus abdominis and pec major as well. We have a lot of patients with buccal mucosa disease. The adverse outcome of these patients is trismus. So less than 2 centimeter defect, probably you need no reconstruction or a skin graft. When the defect is more than 2 centimeter, but not involving the sulci, you can have a buccal pad fat or a nasolabial flap. Defects extending to the sulci, a thin flap is required, which is radial forearm and submental. Submental is preferred as compared to radial forearm because it is not that much thin and it is not that much bulky when compared to ALT. So the defects with partial mandibular or maxillary defect, you can have radial forearm again. For full thickness cheek defects with or without lip loss, ALT, radial forearm free flaps, the larger ones and the pec major may be a solution. The bony defects, you need to look into the Brown's classification. There are lateral defects and then there are anterior defects. For the anterior defects, it's fibula, fibula, and fibula. But for the lateral defect, you have other options as well, like DCIA, when you are building a lateral defect, the ramus, the angle, fibula with skin or with mucosa. And for the extensive reconstruction, where you need a bone and a mobile skin paddle, scapula is a very good option. Few workhorse local regional flaps in the very first picture. Submental flap was applied to the right tongue defect. I told earlier that the only nuisance is the hair growth in the post-operative setting. But again, those hair will go away when the patient receives radiotherapy. Unluckily, if the patient comes back as T1 disease and radiation is spared, then you need to send the patient for electrolysis. In the second picture, it's the, again, submental flap in a female, so no problem of hair growth. And you can see in this picture, a lot of air, and there's a problem of maintaining the oral hygiene. Free flaps, radial forearm flap, right lateral tongue defect, obviously involving more than 30% of the tongue. ELT flap, and for the bony reconstruction, fibula is the gold standard. So there is also a rising trend of organ preservation approach in advanced operable oral cancers. The concept was to downsize the tumor in an effort to convert radical procedure into more conservative one. It's still investigational, and there is no concrete or solid evidence. There are only few published studies, but we need to look into this special treatment protocol. There's one paper by Licitra et al. This is a randomized controlled trial involving 192 patients with T2, T4, N0, N2 disease. 3 cycles of neoadjuvant chemotherapy were offered, surgery versus upfront surgery. So they have compared the 2 groups. The first group was offered neoadjuvant chemotherapy followed by surgery, and the second group was offered upfront surgery. No survival benefit was observed. But mandibulectomy was done in only 31% of patients when treated with adjuvant chemotherapy, as compared to 52% of the patients who were subjected to upfront surgery. And adjuvant RT has to be offered in only 33% of patients when induction chemotherapy was applied, as compared to 46% of the patients where upfront surgery was offered. So we have done one publication in locally advanced oral tongue cancer. The question was, is organ preservation a safe option in resource-limited high-volume center? In our study, induction chemotherapy has an overall response in 87% of the patients at the primary site. Chemotherapy has completely resolved the nodal disease in 17% of the patients. So the effect was more at the primary site rather than at the nodal level. But 23% of patients had failed to respond. So there is no certain criteria of identifying those patients who will fail. Only 21% of these patients received reconstruction using local original flaps. So it has reduced the burden for us. You will also read about a lot about the sentinel lymph node biopsy in oral cavity squamous cell carcinoma. It is based on the same concept that we applied in breast cancer and melanoma. You need to identify the sentinel lymph node, which is the first lymph node to receive the metastasis, using radiotracer, followed by lymphatic mapping. It prevents unnecessary dissections of neck and morbidity associated with it. And it was studied in many quality of life studies. So safe alternative to END in clinically negative early oral cavity squamous cell carcinoma with a sensitivity of 96% and a negative predictive value of 94%. But the problem is still there is no randomized control trial comparing sentinel lymph node biopsy with elective neck dissection. But strong evidence is available about the superiority of elective neck dissection over wait and watch. The debate is settled by Neil D. Cruz. So far, what we know is that we have to address the neck. Despite many US and European trials, the factors which are to be considered is that there is a need for a long learning curve if you want to apply sentinel lymph node biopsy. Additional preoperative workup has to be done, which is involving the radiologist and the lymphatic tracing. And you need to have an expert multidisciplinary team. So the take-home message, do no harm to your patient. Treat them as you're treating your relative or yourself. Combined approach is the key to success. Learn to say no. You need to find a mentor. I have found 2, you need to find yours. Thank you very much. I think we will keep the question and answer session at the end because we have to finish before that.
Thank you, sir, for such a detailed presentation. And now Dr. Rahim, who has also traveled all the way from Lahore to join us, will discuss the management of parotid gland. Dr. Rahim has an FCPS in otolaryngology, and he is a fellow of the Royal College of Physicians and Surgeons, Glasgow. He is currently working as head and neck surgeon at the Department of Surgical Oncology at Shaukat Khanum Memorial Hospital and Research Centre, Lahore.